Is scanning the heart for you? In today's episode, I'm going to talk about the who and why. I believe we can prevent heart attack. We can put in place strategies to reduce risk. We can literally plan to change your future. I call it Healthy Heart Network. Hi, I'm Dr. Warwick Bishop and welcome to the Healthy Heart Network. Well, having covered CT imaging, who can benefit from it? Well, of course we can use CT imaging to investigate chest pain, but personally, I'd like to try and investigate before there's a problem. So who can we help? In my own practice, I tend to see intermediate risk patients who have a number of particular things that have brought them along, for my opinion. Some have high cholesterols. Some don't want to take cholesterol medication. Some have bad family histories. Some are intolerant or have side effects from the medications. Others have high risk factors and they want to be clearer about their individual risk, and some people just come along because they just want to know. But before we start in too much detail, a quick reminder: primary prevention versus secondary prevention. Primary prevention is where we'll be focusing today, and primary prevention is finding a problem before it occurs. I often see patients who want to be best informed. They have asked their local doctor to send them to me for an assessment. Patients with high cholesterol, 6 millimoles per litre or 250 milligrams per decilitre. Quite often the local doctor wants to start medication for lowering cholesterol to treat risk. But as you're aware, there's a lot of information out there, particularly on social media, about cholesterol lowering and particularly the statins. There's all sorts of stuff about them not working, or them causing memory loss, or muscle pains. There's even conspiracy theories that abound on social media. So let me tell you a story. It's a story that you'll have heard in episode 4, and it's about Karen, who's a 60-year-old female. She's fit, no family history of heart disease, no significant risks, but she did have a high cholesterol level, 9 millimoles per litre or 350 milligrams per decilitre. This is what a lipid panel looked like. If we looked at her risk calculator chart, this is what it showed. A red thermometer suggesting that she was at terrible high risk. Her local doctor had wanted to put her on tablets. She didn't want to be on tablets. She had asked to come to me. We had talked about scanning, and that's what we did. You can see her heart showed no evidence in her of the high cholesterol levels, leading to build-up of plaque or problems in her arteries. A 0 calcium score, which is what Karen had, is a very reassuring feature. In studies, we know by looking at over 40,000 people that the risk of a problem is less than 1% in 10 years. It's not so reliable if there's a family history, or if the cholesterol is super high, or if it's a woman, or if the patient's young. But nonetheless, this is a very reassuring finding, and for Karen, we elected to simply keep a close eye on her and monitor over subsequent years, considering repeat imaging if indicated. The next case is two sisters, Tracy and Beck, obviously from the same family, both with elevated cholesterols, both had average build. Neither of them particularly wanted to take medication, so we took some pictures and this is what we saw. You can see Tracy had no evidence of any build-up of plaque in her heart, but Beck, on the other hand, clearly has problems. And in fact, if we compared Beck to other women her age, she was easily in the worst 10 and probably in the worst 2 to 3 if we were to take 100 women randomly off the streets. The same information can then help us inform what we're going to do. We can also use imaging to try and give us some idea of whether a bad family history is actually being passed on to those people within the family, whether other risks are having an impact on what's going on in the arteries. And for people who just want to know, we can also give them some understanding of what the health of their arteries is like, regardless of what they look like on the outside. My general practice is that for people who just want to know, it's generally men at 50 or women at 60 where we start to have that conversation. Scanning gives us the chance to bring more information into the assessment and then make the most precise plan for the individual, potentially you, sitting over the other side of the table, evaluating as much information as possible. Ultimately, to scan or not is up to you and your local doctor. It's just important that both parties are well informed in the discussion that needs to be had. So I've been talking about a way to look at the arteries, at the health of the arteries, to have more precision around risk evaluation. And it sounds great. Well, is there a but? Otherwise we should be doing it everywhere. Well, are there any drawbacks? Well, of course, everything has pros and cons. The pros are clear. You can be clearer about actual risk and you're in a position to tailor management to an individual. But there are cons. The downside at the moment is that in guidelines both in America and in Australia, imaging the heart for risk is not considered a level 1 recommendation. In Australia, there's a cost out of pocket because of this. In the US, there is some legislation which in some states allows there to be funding to support this sort of testing. So there's some variability. Texas, for example, have an ability to support this sort of testing. But either way, if you are out of pocket, it's worth remembering that this sort of imaging will cost you less than a new set of tyres. There's also talk about radiation exposure, so one has to be careful with not imaging people who are too young. My own preference is not men less than 30 years of age or women less than 40 years of age, but that radiation dose is not so high that it's out of the realm of what we're used to. In fact, the radiation dose for this sort of imaging is the same as a mammogram. Occasionally, we inject contrast. There is a small chance of allergic reaction to that. The contrast can also play up with the kidneys, and the imaging may be suboptimal if there are problems with the rhythm of the heart. So it's not for everyone, but it does need to be put in context of pros and cons for the individual. But there is one other possible drawback, and that is related to how the study is reported. This is specifically for individuals in primary prevention, someone who undertakes a test to be proactive. There's no consensus across the medical profession, which means that there are people reporting scans that show even small amounts of plaque or problem in the artery and call that coronary artery disease. I believe this labelling of coronary artery disease for someone without a problem is really important. It can affect the way they think about themselves. It can affect insurance. It could have an impact on their job opportunities. So my strong recommendation is if you do, with discussion with your doctor, decide to proceed to getting your heart scanned in the primary prevention setting, then please make sure they don't use the word disease in there. I've actually written a paper on this which is free to download from the Healthy Heart Network website. It's called Atheroma Burden and relates to the language and the consequences of our language in reports. So, in summary, I'd like you to think about imaging being of value for situations where a bit of extra information can help make the most precise plan for the individual, where extra information may allow a discussion to alleviate concerns that an individual may have, to understand that cardiac CT imaging is not for everyone. It has pros and cons like any test, so it needs to be understood and discussed. And lastly, the language of the report is really important in the risk assessment setting. Please don't use the term coronary artery disease if that's what we're trying to prevent. Anyway, stay tuned. Coming up, I'm going to talk about a case of a broken heart. Hi, well you've just heard a little bit about whether scanning is for you or not, but this case is a different box and dice altogether. I'm going to talk about whether a heart can really be broken emotionally. There really is a broken heart syndrome. It's not an urban myth that occasionally very severe emotional trauma or stress can lead to someone having chest pain and all the features of a heart attack and even occasionally dying from it. This literal breaking of the heart has been recognised in more recent years by the medical community as a syndrome that is referred to as Takotsubo syndrome. It's a bit of a mouthful. Broken heart syndrome will do for us, but this is a Japanese name which refers to the shape of the heart when this condition occurs. And Takotsubo refers to an octopus pot, which is bulbous at the bottom and tight at the top, the shape of the heart when this condition is present. The syndrome is characterised by severe emotional stress affecting the individual. Most commonly, the individual is a female in mid or later life. The symptoms are of severe central chest pain, just like having a heart attack, and essentially are indistinguishable from a heart attack. Except that in broken heart syndrome, the arteries are completely normal. What is found, however, is that when we look at the heart and see how it is functioning, the very tip of the pumping chamber, or the apex of the heart, for some reason stops working. It balloons out and takes on the shape of the octopus pot that I was talking about. Hence the name of the syndrome. Thankfully, in the vast majority of cases, there is full recovery and awareness in the future that stressful events could be challenging and could lead to the same problem. Let me share with you the case of Anne, a 75-year-old woman who fractured her ankle and was waiting for her surgery. She was very anxious about this, and while she was waiting for a surgery, had sudden onset of shortness of breath and chest pain. Initially, we thought she'd had a clot from her leg travel up to her lung, something we call a pulmonary embolism. But when we checked for that, there was no evidence that was the case. We checked her blood tests, and her blood tests showed that there'd been some damage to the heart and that the heart clearly wasn't working properly. Let me show you some of our findings regarding Anne so that you understand a little bit of what we were dealing with. This is Anne's ECG, and I'm not going to go through the details of this, but I'd like to bring your attention to this portion of the ECG, which is dynamic in this lady. It changes. See how it turns upside down? This is a characteristic feature of this particular condition. So having looked at her ECG, let's have a look at what the function of the heart looks like. Remember, I said to you that the distal bit of the pumping chamber of the heart stopped contracting properly. And if you look here, you can see that this area of the heart, the septum is just not moving properly. I have images of this in other planes so that we can tease out that the whole apex of the ventricle is functioning suboptimally. The nice thing, however, for this condition though, is if we wait a little while, and for this lady it was in the order of 6 to 8 weeks, we were able to demonstrate that the function here returned back to normal. And what I'm going to try to do is set those up side by side so that you can compare them. If you look over here, failure of movement, failure of recruitment of the apex of the heart. And over here, that heart contracting properly. Now we can only make the diagnosis of broken heart syndrome if we're absolutely sure that there's no blockages in the arteries. Otherwise we could be dealing with a heart attack. So we have to really be clear that the arteries are absolutely fine. Well, I can reassure you, as I reassured Anne, that everything will turn out well, and for Anne it did. She managed to have her surgery, she had no problems, she's off her crutches, she's mobilising without any issues, and she's not had any further issues with her heart. Stay tuned for this episode's patient question. It's coming right up. Welcome back. For this question and answer, I'm going to jump straight into a question I get regularly from patients and people I meet out on the street and socially. The question is, what can I do for my heart? Well, coronary artery disease remains the largest killer in the Western world, despite advances in our understanding, diagnosis, and management of the condition. Most importantly, a significant amount of suffering could be reduced with attention to simple maintenance. If you've already had a heart attack, you will have met a cardiologist and should be locked in with your local doctor for ongoing management. It is important that you check that you are on all the right tablets and that you are having follow-up for routine bloods and examination on a regular basis, particularly evaluation of symptoms, and particularly just touching base with your specialist, because sometimes our understanding through the literature changes and that needs to be fed back to you. It's a little bit of a different story if you've not had a problem with your heart. This provides the opportunity to work at prevention of developing a problem, and that strikes me as a good idea. So what can you do to reduce your risk of a heart attack? Well, the first thing is simple, and like most things, you have to make a decision. Decide to look after your heart health. This is important. It is easy to say, you'll do this and you'll do that, but unless you make a decision and then commit to follow through, you're kidding yourself, and that won't help you. Next, go and see your family doctor with your decision. Not only will your local doctor check your blood pressure, your blood sugar, your lipid profile or cholesterol profile, plus have an eye to your general health, like how is that tummy coming along. They'll also provide guidance you need to head you in the right direction, and then most importantly, bring you back for follow-up. And that follow-up means accountability, so you're not off the hook. My suggestion is always make small, sustainable changes. There is no point turning your life on its head to go from couch potato to Olympian in a fortnight. If the changes are not sustainable, then guess what? You won't sustain them. Look to change by degrees with your family doctor guiding you so that you get the best bang for your buck in terms of the effort you put in. I'm going to steal a phrase here, but just do it. If you are advised to change lifestyle or take tablets, it will be because your doctor believes it will make a difference to your health. So please, just do it. Ask the experts. If you have questions or you're unsure about the advice you're getting, then please seek out your local doctor for a sensible consultation and discussion, and do this sooner rather than later. My experience is that more and more patients these days seek help from Dr. Google, and this free advice is often worth the money that they pay for it. The information can be biased, and there's no way to make sure it's relevant for you as an individual. Get good advice, and it will pay dividends for the rest of your life. Perhaps you want more information. Modern technology has evolved to now allow us to look at the arteries of the heart in a non-invasive way, meaning not needing to cut or push something into the body. Using CT or CAT scanning, this is a fairly new way of being able to look at the heart, which is not part of any formalised guidelines. The test, however, does provide extra information and in certain situations may be useful for the individual and the doctor involved to tailor best care. The sort of issues imaging the heart arteries may help with are patients who have high cholesterols and wonder if there's a build-up in their arteries. Patients who have a family history of bad hearts and should they be concerned. Patients who perhaps are not sure about taking a medication which has been recommended. Some patients have side effects to lipid-lowering medications, and getting an image of the heart can help us be clear about the intensity of therapy that person may be able to be managed with more adequately and appropriately. Some people just want to know more about their heart because someone near to them has had an event and they want to get checked out. Though not routine and not always covered by a government rebate, some patients choose to pursue this extra information of imaging the heart so they can have the most information available and hence are best informed to make the most important decisions about their future cardiovascular risk. At the end of the day, we want you to live as well as possible for as long as possible. The years fly by, so make the most of them. Keep active, keep a healthy weight, keep in contact with your family doctor, and work on your best health because, as we all know, prevention is better than cure. Well, that concludes this question and answer. Thank you for joining me. I hope you found that informative. I'm sure you're going to be looking forward to our next teaching episode, which will be a heart-pounding one. And please, until next time, don't have a heart attack. Want to know more? Grab a copy of my #1 best-selling book, Know Your Real Risk of Heart Attack. It's available as a hardcover, a paperback, and an audio from Amazon, or wherever good books are sold.